Hello, my name's Nuala and I work in the UK. I'd like to thank the organisers for laying on this fantastic webinar and asking me to contribute. Over the next 10 minutes, I'm going to discuss three areas related to COVID-19 infection in obstetrics. I'm going to look at a little bit of the epidemiology, the provision of anaesthetic care, and lastly, I'm going to touch on some treatment strategies for pregnant women with COVID-19. There's been a huge volume of publications in this area, and I'd particularly like to draw your attention to these three excellent manuscripts. The first is a living systematic review published in the BMJ towards the end of last year. Its findings are updated and available on the University of Birmingham website, and I'd urge you to take a look. The second is a multi-centre international prospective population study, and the third is a population-based cohort study from the UK obstetrics surveillance system. These manuscripts provide valuable insights into the impact of the pandemic on the obstetric population and can help to guide our care. Looking at the clinical features of COVID-19 in obstetrics, similar to the non-obstetric patient, around 40% experience cough, with a slightly smaller proportion experiencing fever, with features such as anosmia and breathlessness appearing less frequently. Around a third of patients have a raised white count, but lymphopenia is present. A small proportion of patients develop thrombocytopenia, and interestingly, this is not necessarily related to the severity of COVID-19 infection. Looking at outcomes in the obstetric population, around 10% of women develop severe disease, with 7% needing advanced oxygen therapy and 4% requiring admission to the intensive care unit. And these proportions are slightly higher than the non-obstetric population. COVID-19 is a risk factor for cesarean delivery, and particularly severe infection, with just over half of women requiring delivery via cesarean section, and just under 20%, this was before 40 weeks. Reassuringly, COVID-19 infection in the mother does not seem to directly lead to an adverse outcome for the infant, and there is no increased stillbirth or intrauterine death rate noted. However, there is an increased risk of admission to the neonatal intensive care unit. This is likely related to prematurity, and I think it's important to also remember that different neonatal intensive care units have variable admission criteria. In terms of risk factors, we know that hypertensive disorders, and in obstetrics this means preeclampsia and eclampsia, and diabetic disorders increase a patient's risk for severe COVID-19 infection. For an obstetric patient, this can mean pre-existing diabetes or gestational diabetes. I think it's also important to highlight that any comorbidity, particularly pulmonary comorbidity, can also increase the risk of severe COVID-19 infection. Moving on to consider the provision of anaesthetic care for this group. The pandemic has introduced a huge amount of uncertainty, but one small area we can take comfort from is that the mainstay in the provision of obstetric anaesthesia and analgesia, regional anaesthesia, is the same for COVID-19 patients as for all our patients. These are recommendations from the UK. Epidural analgesia is recommended for labour analgesia to women with suspected or confirmed COVID-19 to minimise the need for general anaesthesia if urgent delivery is required. And of course, we want to avoid general anaesthesia in this setting because we know that it is associated with aerosol generation and the increased risk of infection to anaesthetists and other healthcare workers. And similarly, for caesarean section, we again prefer regional anaesthesia for the same reasons, to avoid the risk of aerosol generation and increased risk to healthcare workers. So epidural, spinal, or CSE is preferred, as is normal in the obstetric population. If you do find yourself in the position of having to do a GA for caesarean section, I would urge you to use a very protocolized approach. The points I would particularly emphasize are that wearing protective equipment can cause communication difficulties, so a checklist and closed-loop communication can be very valuable. A standardized rapid sequence approach with video laryngoscopy is also, I think, absolutely essential. And lastly, I think I do want to highlight that extubation is also a high-risk time for aerosol generation, and you may want to minimise staff in theatre at this point. This is an interesting study from 6 hospitals in the north of England who compared some anaesthesia data for caesarean sections in the first wave of the pandemic with data from a similar period in 2019. And they looked at change in GA rates for caesarean section and overall caesarean section rates and neonatal outcomes. They found that they were able to reduce GA rates, not just primary GA rates, but regional to general anaesthesia conversion rates in emergency caesarean delivery. They noted a small but non-significant increase in median decision to delivery intervals in this group, but reassuringly, there was no increase in adverse neonatal outcome. How did they achieve this? Well, they attribute it to excellent anaesthetic decision making, the rigid adherence to guidance, and the increased presence of senior anaesthetists available on the maternity unit at this time. And I think this has valuable lessons for many units. Moving on to briefly consider some treatment strategies for pregnant women with COVID-19. We know from studies, the recovery studies and the REMAP-CAP studies, that corticosteroids and tocilizumab have a valuable role to reduce the severity of COVID-19 infection. And these drugs should be used in obstetric patients with the same indications as the non-pregnant population. We know that COVID-19 infection increases the risk of thrombosis in pregnant women who already have an increased background risk of thrombosis. So it's essential that any woman with confirmed or suspected COVID-19 infection receives thromboprophylaxis with low molecular weight heparin. A big discussion point is, where can these patients be cared for? I can't offer you any hard and fast advice, but I think it's important to remember that these patients will require multidisciplinary input, not just from obstetricians and midwives and anaesthetists, but from respiratory physicians and our intensive care colleagues. And I think the ideal location is the place where the MDT are going to be best able to care for this patient. The last point I want to make is about timing of delivery. I've already mentioned that COVID-19 infection is not in itself an indication for caesarean delivery. And I think it's important to use the same maternal and fetal indications for delivery for caesarean section. If you are going to deliver a woman before 40 weeks, remember fetal neuroprotection with magnesium in a very preterm situation. I think that there is some confusion around the use of corticosteroids in this situation, so I just briefly want to touch on this. We use betamethasone and dexamethasone to induce fetal lung maturity because they have the highest rate of placental transfer with minimal mineralocorticoid effects. And we avoid other steroids in this situation because they are extensively metabolized by placental enzymes, leading to reduced placental transfer. However, we also know that exposure to repetitive courses of antenatal glucocorticoids has been associated with adverse neurological outcomes, fetal growth restriction, and an increased risk of neonatal hypoglycemia. So my take-home message is here in terms of which steroid to use in a sick pregnant woman with COVID-19. Well, to treat COVID-19, I think you should be using prednisolone, 40 milligrams once a day, with the same indications as for any patient with COVID-19 infection. If you want to induce fetal lung maturity, if you're planning to deliver that woman, then you should use dexamethasone, 12 milligrams given twice, ideally 12 to 24 hours apart. And remember that any steroid is going to cause problems with the mother's glucose metabolism, which can then in turn lead to problems with the baby's glucose levels. So it's important to keep an eye on blood sugar levels in women who receive steroids. The last thing I just want to mention is this new paper that's just recently come out. This is the preprint, suggesting that the alpha and delta variant of SARS-CoV-2 virus is associated with more severe infection and worse pregnancy outcomes than the wild type infection. Now, as anaesthetists, vaccination is not a core part of what we do, but we do come into very frequent contact with obstetric patients. And I think this knowledge about these variants really behoves us to help women make informed decisions about having vaccinations and advising women that it really is beneficial. And now we're developing a good body of evidence to suggest that there is no adverse outcomes having the vaccination. It confers a huge degree of safety, and pregnant women should be having vaccinations. So just to conclude, 10% of obstetric patients with COVID-19 infection have severe disease. 4% are admitted to ITU. There is a high cesarean section rate, but no adverse neonatal outcome. Regional anaesthesia is preferred for labour and cesarean section anaesthesia. And if you do find yourself in the position of having to do a GA, use a protocolized approach. In terms of treatment strategies, corticosteroids, thromboprophylaxis, tocilizumab are all very important to reduce the severity of infection. And lastly, I would emphasize the value of vaccination. Thank you for listening.